Glabau. I am a medical anthropologist, and I am also the founder and CEO of a research group called Implosion Labs. So a lot of my research has looked at the patient experience in healthcare, how patients learn about their condition, learn about technologies and treatments related to their condition, and also how they get inspired by their experiences to get involved in activism, to build communities, to advocate for their needs, for new treatments, and the like. So I think today we're going to talk a little bit about some of my research on food allergy advocacy in the United States, which was the subject of my dissertation research. So this was an article that kind of initiated some other work around patient advocacy and healthcare for food allergies. So this piece was looking at epinephrine auto-injectors, specifically, which are these devices, a drug-device combination that administers a dose of epinephrine for a person who's experiencing an allergic reaction. So you might have one of these prescribed if you have an allergy to bee stings as well, and food allergies, potentially if you have an allergy to certain drugs. So basically the way it works is it's kind of a spring-loaded mechanism. It's about the size of a Sharpie marker. And if you are experiencing an allergic reaction, you can sort of jab it into your leg. It releases this medication called epinephrine, which we also know as adrenaline, that very rapidly reduces the symptoms and limits the effects of the allergic reaction. So what I found when I set out to do my research was that I would sit down to talk to people who had food allergies or parents of food allergic children and just ask them to tell me about their experiences with the condition. And very often a lot of the conversation would end up being about these epinephrine auto-injectors. People felt very attached to them because they really relied on them in some cases to save their lives. So they were really a central part of the patient experience with food allergies. And so that caught my attention, and I wanted to spend a little bit more time thinking about all the different ways that they impact life with food allergies. So the article kind of follows the device itself through the different ways that patients use it and encounter it and learn about it. So we kind of start off in the clinical encounter. How do physicians introduce this device to patients? How do they educate them on it? What do patients take away from that interaction, which isn't always what the physician intends? And then from there, how does this device affect their relationships in their communities, relationships with schools if they have allergic children? How does it affect family relationships? And then I kind of end the piece by looking at how talk about epinephrine auto-injectors is actually a key aspect of how the food allergy community builds a community. So both people with food allergies, adults with food allergies, and parents of allergic children spend a lot of time talking about these devices, about how they save their lives, exchanging news about them, exchanging updates about the new research or new devices on the market. And so it's really a way for people to connect by talking about their shared experience around this technology and build a community, which then has other effects down the road. As an anthropologist, I'm really using what are called ethnographic methods. So it's a very kind of open-ended research method in some ways, where you really kind of go in and you talk to people. Some people call it deep hanging out. You follow people through their daily lives and really understand what they think about their lives and also observe what they do. Sometimes there's a little bit of a mismatch. So this is a method that I use for researching food allergy and for my more recent research as well. And so a lot of my research was interviews with people, attending events, food allergy advocacy events, and things like that. And I think it reveals a side of medicine that we often overlook, right? We talk a lot about the economics of healthcare. We talk a lot about investments. We talk a lot about cutting-edge technologies. But we don't spend as much time, I think, as a society really sitting down and listening in a detailed way to how people experience that, how patients experience that. So I think these kind of ethnographic, deep hanging out methods lets you really get inside of people's lives and understand what it looks like from an everyday perspective to be dealing with the medical industry, to be learning about medical treatments, to be a patient. I think there's a lot of sort of ethical and moral questions. The title of the article, The Moral Life of Epinephrine in the United States, kind of gives that away. I think one of the places where there is maybe a little bit of a dilemma is when patients are faced with an emergency situation, when they are starting to experience an allergic reaction and making the decision of whether or not to use their auto-injector. So there's a couple of dilemmas going on there. I think one of the big dilemmas that people face is cost, right? So these devices have become much more costly over the last 10 years or so. And so using one might eventually cost a person several $100s out of pocket to replace it, right? So there's often a calculation nowadays for people kind of deciding, is this a serious enough reaction, a serious enough situation that I can afford to go out and replace this device after for the next time? I think there's another dilemma, and one that is, again, the kind of story that we don't hear as much about medicine. And that is a dilemma where people are, especially adults with food allergies, are trying to decide whether the situation is serious enough to use the auto-injector and to get the appropriate follow-up treatment, which means it means that they're not going to be able to follow through on their responsibilities for the rest of the day, right? They're probably going to have to go to the ER, they might have a follow-up doctor's visit, they might feel very tired after using the medication, and so on and so forth. So there's always this decision-making process about, can I sort of let down all of those people in my life? Can I sort of skip all those other obligations to take care of myself in this moment? From the outside, it's easy to say, yes, of course you should. You should always put your health first. But when you are a person balancing a lot of responsibilities, a lot of different people that you might be responsible or loyal to, it can be a very difficult decision. Part of the reason I draw on Cheryl Mattingly's work is that she does a really good job thinking about the sort of clinical encounter between patients or parents of patients and physicians. And one of the things that's really at stake there, as you mentioned, are some of these socioeconomic factors, right? It might be in sort of obvious ways, right? And that a doctor is recommending that a patient get a treatment that the patient sort of knows that they can't afford, or they're not sure that they can afford, right? So that might make them a little bit suspicious, a little bit hesitant in that interaction. And the doctor's not necessarily going to know why. So I think there's sort of that level of things that I think it's really important for physicians to keep in mind. I think and then there's this other layer of different understandings of what is right and good, right? Again, so this kind of moral question. So again, I think for a patient, there's a lot of things that they might be thinking about when they're thinking about what is a good treatment. Right? It might be a treatment that doesn't have too many side effects so they can keep living their life. It might be a treatment that does treat long-term potential outcomes of a condition. It might be a treatment that is accessible to them, is financially accessible to them, or is offered in a location that is convenient, where they can take a reasonable amount of time off of work, where they won't lose their job to access the treatment. So there are all of these factors, some of which are tied to socioeconomics, some of which might be tied to other sort of community expectations about involvement in community or family events. And again, I think these often get lost in that, especially in the patient-physician encounter, and especially nowadays when we're really crunched for time in that encounter, when physicians might be trying to fit in 6 or 8 patients in an hour. So I really like her work for really exposing that and really thinking through the socioeconomic piece of it. I think in food allergy, again, I talked a little bit about how price or cost of epinephrine auto-injectors might fit into a patient's decision to use it. So I think that a similar dilemma is there in food allergy as well. And of course, it's specific to each condition. It's specific to each patient. It's specific to each person's community and family and cultural life. Medicine, as a rule, doesn't really know how to handle those specifics anymore. I think modern medicine is really has made great strides by trying to standardize diagnoses, standardize treatments, but because of the way that we manage these physician-patient encounters, there's often not a chance to sort of step back and think about, well, could I be asking other questions? Might there be some family, social, cultural factors that are potentially affecting how these rules could be applied in an individual's case? The hospital, or we can sort of think more broadly, the sort of clinical facility, maybe, it's a context for a lot of these interactions. And it structures what can happen in a doctor-patient interaction. That means that it also structures how a patient encounters information about their condition, how a patient encounters information about treatment, and can really sort of shape how they feel about it and what they feel is accessible or doable to them. So, in a way, we might think of the doctor-patient interaction not as starting when the doctor and patient sit down together, but as starting as soon as the patient walks into the facility. And so then I think there's this question of how do we structure not only healthcare delivery in terms of diagnosis and treatments and prescriptions and all the infrastructure there, but also how do we structure the entire experience of being in a healthcare setting for a patient? I actually, one way that people are starting to think about this, especially in Europe, is through the lens of something called service design. So thinking about what does a service look like from the person using it, so in this case from the patient perspective, and how can we kind of drill down into all of the different steps, all of the different encounters that the individual has, from their encounter with the space, their experience in the parking lot, their experience with the receptionist, their experience with the biller, as well as their experience in the clinic room and with their physician. How can you kind of drill down and make each one of those work as well as possible, right? Some of those solutions might be technological. It might mean having good technological infrastructure. It might mean having the right digital or EMR tools to make interaction seamless. Some of those might be on the side of personnel and training and making sure people are really knowledgeable about their particular role, but also a little bit knowledgeable about the other roles of people in the office so that they can facilitate the person getting getting what they need within the context. And then some of that, of course, is really based on, again, the sort of medical knowledge of the providers, the physicians, the nurses, the nurse practitioners, the physician's assistants, the laboratory technicians, and so on. And making sure that you have the right kind of cast of characters and the right kinds of expertise to provide the service that someone needs when they walk in. So I think that's a really potent way to be thinking about healthcare delivery and to be thinking about healthcare facilities right now. Another piece of all of this is also, what is a patient prepared for? What are they educated about? So again, we've been talking about where that education happens, or where some of it happens in that doctor-patient interaction. But there's a lot more that goes on there as well, right? So in the case of epinephrine auto-injectors, there's actually a lot of support for patient education and patient preparedness from the pharmaceutical companies that produce these devices, as well as from a whole host of patient advocacy organizations. So, on the pharmaceutical company side, there are educational videos demonstrating how to use the device. And on the patient advocacy side, there are some advocacy groups that directly provide educational materials like forms for schools or for colleagues to learn how to use the device, videos demonstrating the device, webinar series talking about updates and developments and new improvements to how to use the device. as well as support for local support groups. There are a couple of organizations like Kids with Food Allergies or the Food Allergy Research and Education Organization, FAIR, that both support local support groups where individuals who are facing a new diagnosis themselves or in the family can go find local experts, learn about their experience, and also learn about all of these preparedness techniques. One of the things about food allergies is that pharmaceutical preparedness, being prepared with an epinephrine auto-injector, being ready to use it, it's only one piece of a much larger puzzle. There's a lot of steps that come before that where you could be preventing an allergic reaction in the first place, right? So things like asking the right questions of your waiter when you eat out. Things like learning how to read a food label, to know all the different names that your allergen might go by, and to know to avoid it, to know which brands might be manufactured in a facility that's safe for you, which brands might not be. And even to sort of change your cooking techniques and change your kitchen organization techniques to make sure that foods that are safe for you are isolated from materials that might not be. So there's a whole lot of other preparedness that goes on, and a lot of that happens in the community. A lot of that happens in those local support group settings. A lot of that information comes through some of these national or regional patient advocacy groups. So there's really a lot more going on that we don't think of necessarily as medicine. It looks like it's about food and cooking, but it actually has these very important medical effects for people with food allergies. So there is a lot of information out there, but there's always more ways to amplify it. So one of the things I really saw a lot of in my research was patients and patient advocates in the food allergy community using the internet to disseminate some of this information. So using more sort of traditional tools like email listservs, as well as newer tools like webinars, like Twitter, like Facebook groups. So again, there's a lot of resources out there that are kind of, organized from within the community. And one of the really important things that I see patient advocacy groups doing is kind of identifying some of those best community-based resources and amplifying them, making sure that more people know about them, making sure that the many thousands or maybe over 1 million people on a large organization's listserv know about this one Facebook group or this one writer who writes really well about some of these everyday management techniques. So again, I think there's kind of an ecosystem here between individuals, local groups, these sort of dispersed online groups, and then some of the bigger organizations that can aggregate and really help to popularize some of the information. One of the things that we value as a culture, and especially in medicine, is a quick fix or the magic bullet, right? We're always kind of searching for the next tool, the next technology that can kind of fix all of our problems, right? And this is very much the kind of mode of thinking in Silicon Valley nowadays, right? Is that you can find a problem and find a fix and the problem's gone. When there's actually sort of more steps involving adoption and involving sort of the changing environment that might change what the right fix is, right? It's actually very complicated to come up with a good fix for a difficult problem. So I think that we're especially vulnerable to this kind of thinking in medicine, right? Whereas, as we've been discussing today, there's actually all of these questions about identity, about community support, about socioeconomics, about individual encounters in the clinic, about the design of services and facilities that can really shape whether someone even encounters a medical fix or medical treatment in the right frame of mind to appreciate it, right? So I think when we're thinking about new technologies in healthcare, it's great to think about them as fixes to problems today, but I think we also need to be thinking about how is the introduction of a fix going to even change what the problem is? Or also, what problems can the inventor of some kind of technological fix not even see from where they are in society, from where they are geographically, from where they are professionally, right? An engineer is going to think of different solutions to a healthcare problem than I would as an anthropologist, and a doctor would probably think of even different ones again. So I think when we're thinking about technological fixes, I think we need to appreciate that there's always going to be improvements that will need to be made, and I think we should also appreciate that we really need a kind of broad set of experts and a broad set of knowledges to design solutions to healthcare problems. A lot of people managing food allergies do feel empowered by having their auto-injectors on them, right? Once they learn how to use them, once they learn to trust them, especially if they learn about them in the context of a physician interaction that really builds some of that trust and makes them feel that they have a responsible partner on the other side, it can feel very empowering, right? To say something might go wrong, but I am prepared and I know that I can save myself. I know that I can treat myself. I know that the steps that I need to go through to make sure that I'm going to stay healthy and well and be able to be here back up on my feet, ready to go tomorrow, right? So I definitely think there's that, but I also think that there's a little bit of a risk sometimes in the way that we talk about patient empowerment with putting all of the responsibility on the patient. And again, I think this goes back to thinking about services and thinking about the doctor-patient interaction. The patient certainly should feel empowered and should have the tools that they need to get through their daily lives. That is absolutely necessary. But they should also know that they have a team behind them that they can turn to troubleshoot, a team that might include physicians, but might also include, in the case of food allergies, a dietitian. Or some other kind of food expert or food coach who can coach them through some of those other preventive steps that I mentioned, like how to cook something safe, how to store food safely, how to read a food label, things like that. This sort of broader set of preventive steps. So I think when we think about empowerment, I think it's really an important thing, but I think we should also think about the broader context and who else should be there sort of helping the patient stay empowered, helping the patient feel empowered over time, not just in that moment when they learn something new and they feel like they're ready to take on a new challenge. I think that's a more difficult challenge, again, given the way the healthcare is organized today, organized around sick care rather than healthcare. I think it's really a challenge to help patients continue to feel supported and continue to feel empowered. So one of the things I talk about in my research is this kind of tension between two sides of medicine today. On the one hand, medicine is this very sort of morally driven field, right? It's about making people healthy and often saving their lives, right? It's about making sure that people can get up every day and be a member of a community, be a member of a family. And that they can do that safely and energetically and happily. So there's a very moral and ethical side to it. At the same time, healthcare is a business. And I think epinephrine auto-injectors really exemplify some of those tensions where, again, they are this device that can make patients feel empowered. They are a device that is life-saving and has that kind of moral connotation to it. And yet they're also a very expensive object, right? They are often reimbursed by insurance, but often only reimbursed by insurance once per year, and someone may need to purchase them 2 or 3 times per year. So there is a financial aspect to it, and again, I think it really creates this tension, and it often puts individuals in a difficult place, kind of balancing whether they want to pursue the right treatment that they know is right, or do what they know they need to maintain their financial stability. So I think it's a really big tension, and I think we've really been at a crossroads in the last 5 years or so of deciding as a country and as a society here in the United States, how do we want to resolve that? Whose responsibility is it? And I think that's still an open question with ongoing debates about healthcare in the US Congress right now. I think there's a number of things that we can think about on the policy side. I think a broader understanding of what care is necessary is really important. So one of the things that the ACA really tried to push was including preventive care, including your sort of yearly checkup as necessary care. And I think that's a great first step, but I think we can broaden that to include not only a yearly physical, but also maintaining some of the new protections under the ACA for mental health care as well. Maybe looking at some of these other kinds of specialists, like dietitians or like nutrition experts in the food allergy realm, who can help prevent people from getting sick in the first place, right? So I think a broader conception of what is necessary, and also a more flexible conception. What's necessary for someone with food allergies is going to look different from what's necessary for someone with cancer. And that's going to look different from what's necessary for someone with a broken limb. Right? So again, I think healthcare has made great strides by designing one-size-fits-all treatments. But now we're at a point where we have so many of those that we need to start digging in and start creating some more flexibility within policy, within health insurance, within the system overall, for people to combine the right treatments for them. And I think this is especially important, as you say, for low-income people, people relying on Medicaid and Medicare. So I think social media is playing a huge role in patient empowerment and patient advocacy. One of the ways that I like to think about this is borrowing from the work of a sociologist named Stephen Epstein. So he writes about AIDS activists in the 1980s and 1990s, and he talks about the way that they become lay experts and develop lay expertise and credibility. So basically, he talks about how this group of young, mostly young activists, mostly without scientific training, are facing this crisis in their communities where many of their friends are becoming sick and dying in the prime of their life, in the AIDS crisis in the 80s and 90s. And one of the ways they respond to this is becoming scientific experts. They get textbooks, they recruit scientists, they start reading all of the scientific papers, and they become really strong experts on how clinical trials are done, on the biology of HIV and AIDS, and start putting this together and start actually proposing new clinical trials, start discovering medicines being tested outside of the United States and getting them tested in the United States, and really influencing science and policy around the approval of drugs for HIV and AIDS. So all of this is what Epstein refers to as lay expertise or patient experts. And so I think social media is now playing a role in this because it allows, again, these sort of local community groups, local support groups, for example, to find each other online, to collect and share all of their knowledge, to potentially build larger regional or national institutions, and to really present knowledge coming up from patient experience as authoritative, as official. And so in food allergies, you actually see this very clearly in some of the changing regulations around food labeling and around the new, so for example, patient advocacy groups were strongly involved in the process of getting sesame on the way to being listed as a top food allergen that needs to be labeled on food packages. So this has been in the works for a number of years in the U.S. And was really pushed by mothers of food allergic children specifically, getting involved in science and policy. Another place you see this is around some of the gluten-free labeling standards. There are a number of testing companies out there that were involved in facilitating some of those some of those new guidelines, and a lot of those individuals at those companies had ties to food allergies and celiac disease. So you see people really getting involved and really using their expertise based on how do I cook a safe meal for myself, and turning it into policy and combining it with scientific knowledge to really have an impact. So I think social media is really facilitating a lot of that today, and it's a really important tool for patient advocates. I refer to this phenomenon that I call death talk in my research. It's actually a word that I borrowed from a patient advocate, and it's basically a phenomenon of telling scary stories about food allergies to get the broader public inspired to support people with food allergies, support policies that support people with food allergies, and take action in their communities to protect people with food allergies. So basically, it's this sort of genre of story that I've followed, of telling the stories of children who, for example, pass away after accidentally eating a food with peanuts at school, or someone who accidentally eats a meal cooked with shrimp when they're allergic to shrimp in a restaurant. These very scary, very tragic stories that really expose some real needs for accessibility to treatment and broader knowledge of some of these food safety preventive strategies. At the same time, I think they also form a kind of touch point within the community, right? There are certain stories that everyone who is engaged in food allergy advocacy knows about. There are certain individuals, scenarios that everyone's very familiar with, and so it becomes kind of a common language for thinking about what is this problem of food allergies, right? Part of the problem is that it's potentially deadly, and you have the evidence of that from these stories. And it also becomes part of the communication strategy and potentially the solution, right? How do you communicate to the public how serious this issue is and how they should be paying attention to it? Part of that is through telling these death talk stories. So they play a number of roles in the community. And sometimes they're very effective, and but there's also a sort of risk that the sort of general public gets overwhelmed by them as well. And so I think there's always a sort of careful management of how much is the community talking about these stories and trying to get the word out, versus how can we be more effective in not only telling the scary stories, but also telling about the triumphs of individuals living with food allergies well? How can we also propose some solutions? How can we also sort of get involved in the activities that would bring those solutions to life? So it's kind of one piece of a broader, again, sort of platform in food allergy advocacy, but it's certainly a very important one.
So let's backtrack to before a person even know that they have an allergy issue. How do you even go about figuring out that there is an issue in terms of allergies? And I guess my question is, how do you figure that out before fatality steps in?
I think that's one of the most frustrating things about food allergies for a lot of people, is that the diagnostic process is sort of from a medical side is very much backed up by science, but from the patient side, it doesn't always make sense because it works a little bit differently than diagnosis for other conditions. So for a lot of things, we can sort of go into the doctor's office and there'll be like one or two telltale signs that we have a particular condition or illness. It might be related to our temperature. It might be related to the sound of our heartbeat. There might be a definitive diagnosis from a blood test that the levels of something are too high or too low, and that means that we have such and such a disease. With food allergy, the process is actually the most reliable process is actually to try to provoke a food allergy, and that is one of the most definitive ways to diagnose a food allergy. So doing a very controlled test in the doctor's office sometimes a skin test to see if you have a reaction to a food substance exposed to your skin. Sometimes an actual food challenge. The most definitive one is a food challenge. So even the thing that you think you're allergic to in the doctor's office in a controlled way, and seeing if you react. So it's this process that is very different from other diagnostic processes. If you're asked to do a food challenge and you are pretty sure that something made you sick and then you have to eat it again, it can be extremely scary. So it's a really stressful process. On the flip side, though, as people are trying to figure out what they're allergic to, they might start eliminating several foods, and maybe one of them is the thing they're allergic to, but they've now eliminated 5 or 10 foods in their diet. And that can then potentially cause some dietary issues, right? Not getting enough of certain nutrients and things like that. So it is actually very important to get a solid diagnosis based on the clinical tests that a doctor deems appropriate, and also based on giving your physician a truthful history of your reactions, truthful and accurate history. So it's a very complicated process that can be very filled with fear, and you might be continuing to be sick as this is going on as well. So it's really difficult. Joseph Dumit, who is an anthropologist of medicine and technology, has a nice phrase for this kind of thing. He calls certain diseases, he calls illnesses you have to fight to get. Right? So something where the diagnostic process isn't very clear, where there's maybe a lot of overlap between different conditions, and he really highlights the work and the stress and also the community building that goes on around certain conditions like that. And I think food allergies in some ways really fits into that category of illnesses you have to fight to get because the diagnostic process is so unusual.
Okay, so let's focus on children. What is the appropriate age to test a child to know whether or not they have food allergies?
So I'm not a physician, okay? So I can't say anything, with a physician's authority here. But food allergies can occur very, very early in life. I know a lot of the research is focused especially on what happens in terms of reactions and exposure starting around 4 months. But certainly in interviews that I've conducted with parents, some of them have reported children as young as a few weeks old or a couple of months old having reactions. So at that point, really the option is eliminating things that you think your child is allergic to, and really talking to your physician to understand when other testing or measures might be appropriate.
Right. So based on your research and your expertise on the issue, what is the number one physical reaction to a food allergy?
Yeah, so again, this is part of what makes it so tricky and what gives it that illness you have to fight to get kind of sense of. So the list of symptoms that could be caused by food allergy is very long, and the sort of resulting condition is collectively referred to as anaphylaxis. So a allergic reaction that can involve as few as one, but potentially multiple different systems of the body. Some typical symptoms might include stomach upset, vomiting, diarrhea, might include respiratory symptoms like difficulty breathing, wheezing, things like that. Might include cardiovascular symptoms like lightness, lightheadedness, or other things. So it might include things like rashes as well. So it can include a really wide variety of things, and it might be different for the person, might be different for the food, and so that's part of what makes it so challenging, is that it is very variable, and each individual has to really learn for the signs that indicate an allergy for them over time. So this was this really interesting interview that I conducted with a woman who's a nurse, and this was a case where her very young son was displaying symptoms of an allergic reaction. And the decision-making process for her included some of those elements that we talked about earlier, right? Especially considerations of how much time would it take to take her son to the ER, and how would that potentially affect other responsibilities that she had on her plate. The other thing for her is that since she was a nurse, she knew that she had some of the expertise necessary to take care of her son, even if the reaction was serious, right? So she talks about how she knows the real signs of danger, signs of kidney failure or signs of other serious illness that might result from an allergic reaction. And so she was on the lookout for those and managing those in her home rather than taking her son directly to the emergency room. Eventually, his symptoms started to subside with that home care she was able to offer him, and all turned out very well. But again, I think it really illustrates how many factors go into deciding what to do in a moment of emergency around food allergies or potentially around another illness that has sort of more severe episodes in a similar way that food allergy does. And I think it also illuminates something interesting about what medical professionals sometimes call compliance or adherence, right? These concepts that from the medical side are really about, is the patient doing what I, as a physician, told them to do? Are they doing it every single time in the way that I want them to, or that I think they should? There's actually a lot of factors that go into not having perfect compliance or not having perfect adherence that are social factors that are related to an individual's experience, related in the case of Nurse Shelley to her expertise as a nurse and her confidence in her ability to manage most of the symptoms of anaphylaxis at home. And I think these things are often overlooked when we talk about compliance and adherence. I also have a memory of another conversation I had, not related to food allergies, but an acquaintance was telling me about an older relative who had been getting prescriptions for diabetes medication for a long time, kept going back to their doctor, and their symptoms weren't improving, and the doctor wasn't really sure why. It turned out that the person had been hiding some of their medication under their bed because it didn't make them feel good. And no one ever sat down to ask, how is this medication making you feel? So that's another kind of complication to what seems to be a simple story of are you taking medication or not, but is actually also about the experience of taking medication and how a medical intervention might be affecting other parts of someone's lives. There's a couple of things that you can pull out of this study and out of this sort of multi-year work that it comes out of. I think one is the importance of patient advocacy for educating patients, right? I think you see this a lot with food allergies, again, because you do have epinephrine auto-injectors, which can treat an acute emergency allergic reaction, but you do then also have all of these other things like safe food preparation, like reading labels, like having community support to keep allergens out of classrooms for small children, and so on and so forth. So I think as physicians or as healthcare providers more generally, I think people should remain aware of some of those other social contexts and social factors and get interested in them. Ask the person across the table from you, well, what are some other things you're doing to deal with this on a day-to-day basis that are not the medications I'm prescribing you? And I think that will likely illuminate a lot of other ways to talk about treatment, to talk about their condition, and new kinds of recommendations that one can make. I think another thing to pull out of here is, again, this reminder that what may feel like an obvious technical or technological intervention on the part of the provider, I'm going to write your prescription, you take your medication every day in this way, in this time, is actually fitting into a lot more complicated dynamics in the life of the patient. And again, taking the time to ask, okay, tell me how you're going to take this medication. Tell me why you might not take this medication. getting into some of those more contextual questions and being able to anticipate and respond to them, I think is a very important thing to consider. And I think that's also at this moral side of medicine. The medicine isn't just about treating our bodies, it's about by treating our bodies, it actually lets us be sort of full social and moral actors. And appreciating how complex and difficult that is, I think sort of could really heighten the sort of respect and importance of medicine and medical care in some ways. So those are a couple of the things that I think could be pulled out of this paper. Well, I think in the case of food allergies, a really big part of treatment, if you want to say, or of prevention strategies is actually community-based, right? So it's making sure that chefs and cooks in your community know enough about food allergies to respond when someone in a restaurant says they have a food allergy. It's about teachers and school employees knowing enough about food allergies to know how to adequately clean tables or desks in classrooms to make sure that there's no peanut butter smeared on a desk or something like that. So there are a lot of community steps that can be taken around food allergies in particular. But again, I think that that's not how we typically think of medicine and of illness in the United States. We typically think of it as an individual problem that is in an individual's body. But there's actually all of these social and community issues, not only about how you get treatment, but also how to prevent illness. And so I think each of us can be sort of individually more appreciative of that and more interested in saying, okay, is there one or two small things that I can do in my behavior that will make it safe for someone else, that will help someone else live a more healthful, productive life. I think patient advocacy is becoming a bigger and bigger part of the healthcare environment, especially in the United States. I think it's also becoming increasingly more consolidated and more professionalized. So there's a lot of back and forth between patient advocacy groups and healthcare groups like insurers and pharmaceutical companies. And in some cases becoming more closely aligned with pharmaceutical companies. So I think that's good because it gives some of these groups a larger reach and a larger voice in healthcare. But I also think that it's very important to consider how can we maintain the independence of patient advocacy, and how can we make sure that it's really representing the interests and needs of patients and not the interests and needs of actors who are already well represented in the healthcare system. So I think that's a challenge for patient advocacy: how to grow but maintain that fidelity to the needs of people who don't necessarily have a voice. So I am the founder and CEO of a ethnographic research company called Implosion Labs, and we do ethnography-driven research on healthcare and technology, really thinking about users and patients and how their perspective can improve company strategy, product design, and marketing research.